Very warm welcome to everybody. Thank you all for coming to this program. I'd also like to take this opportunity to thank the eminent doctors, Dr. Venkatraman sir and Dr. A.K. Singh, who very gracefully and readily accepted our invitation to be part of this program this evening. Thank you, sirs. The SGLT2 inhibitors are a new group of drugs, and we heard a brief introduction about them from the previous speakers. These drugs have actually added a new dimension to the management of diabetes, and like Dr. Samit was saying in his introduction, have actually changed the way that we even look at the disease. This is a slide which evolution of diabetes management. The management of diabetes has actually evolved over the past 100 years or so, as early as 1922 when Banting and Best discovered insulin, following which we then had the sulfonylureas, which were the first drugs which came into the market for the management of type 2 diabetes, which the good old sulfonylureas, following which metformin came into the market. And I think these two drugs still stand tall in the management of type 2 diabetes. We cannot still underestimate these drugs and their role in the management of type 2 diabetes. After that, as we can see, like we were hearing from the chairman's address, into the market, and there's been a splurge of drugs over the past 20 years or so, following the major group of drugs which have actually left a huge mark in the management of type 2 diabetes, in the history of the management, are the incretin therapy and the GLP-1 analogs and the DPP-4 inhibitors, which are another group of drugs which have again actually completely changed the way that we manage type 2 diabetes. And I think these groups of drugs have actually given clinicians an opportunity to treat type 2 diabetes without the risk of hypoglycemia. And following that, of course, I think it's probably even safe to say that the past 10 years until very recently can actually be called the incretin decade in the management of diabetes. Of course, now we have these new groups of drugs, the SGLT2 inhibitors. The SGLT2 inhibitors have actually added, like I said, a new dimension and actually brought to light the role of the kidney in the management and in the pathophysiology of diabetes. So the kidney has actually been brought to limelight. So what is the role of the kidney in the pathophysiology of diabetes? Now, the kidney is not just an end organ and not just a target for diabetes complications in the form of nephropathy or kidney failure or chronic kidney diabetic nephropathy, but the kidney also plays a major role in glucose homeostasis. And this is through gluconeogenesis and glucose production, glucose utilization as well, and also glucose filtration and excretion, which is what is very relevant to these newer groups of drugs. So how does glucose filtration and excretion actually take place? So learning more about that will actually help us understand exactly how these drugs work. The transporters which are responsible for the reabsorption of glucose and the reabsorption of the glucose from the glomerular level is at the nephron level is actually what are called the sodium glucose linked transporters, the SGLT2 and 1. And SGLT2 is what is majorly responsible for the absorption. So glucose, which is basically passing through the blood, glucose which is passing through the blood is filtered at the glomerulus, which then passes through the lumen of the nephron. And in the proximal convoluted tubule, we have the reabsorption of glucose that is taking place through the SGLT2 transporter. And 90%, although SGLT2 has a lower affinity for glucose, it has a higher reabsorbing capacity. And as a result, 90% of absorption of the glucose takes place through the SGLT2 inhibitors in the proximal convoluted tubule. The remaining 10% is through the SGLT1, which has a high affinity for glucose, but the capacity is much lower. So the difference between both the SGLT1 and 2 is, like I said, SGLT1 has a higher affinity but a lower capacity and is only responsible for about 10% of reabsorption in the kidneys. It has a more important role to play with the reabsorption at the intestinal level. Whereas, in contrast, SGLT2 is responsible for 90% of the absorption at the nephron level in the absorption of glucose, reabsorption of glucose. So this is normal physiology. This is what exactly takes place when glucose is filtered and reabsorbed in the nephron. So glucose that is filtered by the glomerulus passes through the lumen, and the SGLT2 is responsible for the reabsorption of glucose back into the blood. And as a result, in a normal person without type 2 diabetes, or in fact without renal glycosuria, which is another condition, we have absolutely almost nil glucose present in the urine. So most of the glucose that is filtered through the proximal convoluted tubule that is filtered through the glomerulus is reabsorbed at the proximal convoluted tubule, and we almost have nil glucose in the urine present in normal physiological state. So what happens in type 2 diabetes? Yeah, before that, this is actually a slide which I think you will have to click on that, if you could. Can you click on, just click on this, yeah. It's an animated slide, so on click it will appear. On it, yeah. Yes. Click pandringla. Okay, sorry, this was basically just a slide that would actually show us at the molecular level how the SGLT2 transporter actually works. So I'll just explain it since we do not have, it was a very nice slide actually, it doesn't seem to be working now. But at the basolateral membrane, we have the cell, and in the, we have on one side the lumen of the glomerulus, and on the other side we have the interstitial space or the blood. So the sodium glucose transporter 2, what it basically does is that it's a co-transporter. So when there is reabsorption of glucose from the lumen into the cell, not only glucose but also sodium re-enters into the cell. And from the cell, it then goes through the GLUT2 into the interstitial space, which is how glucose is basically reabsorbed. And the sodium, which is also absorbed into the cell, I wish the slide was there, it would have been beautiful, but it's a very nice slide, it's an animated slide. So if they could get that to work, it would be great. But the sodium that is reabsorbed into the cell is also reabsorbed through the sodium-potassium ARD. Okay. It's a good venue, yeah. So anyway, so this is how the molecular level of the SGLT2. If we understand this, basically the concept that we need to understand from this molecular mechanics of this is that both along with glucose, sodium is also reabsorbed into the interstitial space through the SGLT2 transporter. So moving on. We'll move on to the next slide. That's okay, we'll move on. Doesn't seem to be working.
We can come back to that later.
Yeah, we'll move on to the next slide. Slide 10. Thank you. Now what happens in type 2 diabetes? Now that we've looked at the normal physiology of glucose reabsorption and filtration at the glomerular level, what happens in type 2 diabetes is that there is an overexpression of both SGLT2 and GLUT2. Both the transporters have an overexpression in type 2 diabetes, and as a result, so here you have the SGLT2 in normal versus healthy subjects, and here we have GLUT2, and due to the overexpression of both these transporters, we have hyperglycemia in type 2 diabetes. So now going back to the same slide that we saw previously in normal physiology, this is what happens in type 2 diabetes. Glucose that is filtered at the glomerulus is usually in normal state reabsorbed by the SGLT2 inhibitor. In type 2 diabetes, what happens? There is an overexpression of SGLT2, and as a result, due to the reabsorption, there is hyperglycemia. And also, of course, we have high blood glucose levels. And there is also one more pathophysiological feature is that there is also a higher renal glucose threshold that is in type 2 diabetes. Now, what happens when we give an SGLT2 inhibitor is that the SGLT2 transporter is inhibited, and as a result, this level of reabsorption is stopped. Okay. So, As a result, the reabsorption is actually inhibited and we have increased amount of glucose which is excreted through the urine in patients with type 2 diabetes. So this is what exactly the sodium glucose transporters 2 have their action through. So what is the rationale of SGLT2 inhibition? The rationale is that through inhibiting the SGLT2 transporter, we have increased glucose reabsorption at the proximal convoluted tubule. As a result, there is increased renal glycosuria, which leads to a decline in the plasma glucose level and also has the capacity to correct glucotoxicity. And this is something which is a completely new, unique, completely different mechanism of action compared to all the other groups of drugs that we have had so far in the management of diabetes. And as the glucose passes through the urine, we have calorie loss. And with glucose loss and with calorie loss, the patient also has a tendency to lose weight. So what are the SGLT2 inhibitors that we have in the market? We have canagliflozin, which was the first to be marketed in India, following which we have dapagliflozin. Canagliflozin was from Johnson & Johnson, and the trade name of canagliflozin is Invokana. We have 100 mg available in India, and it's an OD dosing. Dapagliflozin, trade name is Forxiga from AstraZeneca, and the dosage is 10 milligrams and 5 mg is the lower strength. We have both the strengths available in India, and that is also an OD dosing. So DAPA and canagliflozin are the two commercially available SGLT2 inhibitors that we currently have available for clinical use in India. Other than that, there is also empagliflozin and ipragliflozin, which are both not yet available in India. Now, so what is the efficacy? How good are these drugs? When we use them in the management, how powerful are they as agents? This is a slide to show that they are quite effective. The HbA1c reduction is around 0.8 to up to even 1.2%. In monotherapy, it's around 0.89. As add-on to metformin, it's around 0.8. So the average HbA1c reduction is around 0.8 to 1%. And this is with dapagliflozin 10 mg. It can be combined even with metformin, glimepiride, and even combined with insulin, and we have almost equal efficacy. This is in subjects with a higher HbA1c around 9, and when we start off with when there are patients with higher HbA1c or higher levels of glucose, there is a higher drop, more significant drop in the HbA1c, which is expected. And this is a slide which shows the same thing. Dapagliflozin versus placebo in monotherapy, add-on to metformin, sulfonylurea, DPP4 inhibitors. And what is unique about them is that because they have a completely different mechanism of action, they can be combined with almost any other group of anti-diabetic agents. And this is to show that higher the HbA1c, the more significant the drop in blood glucose levels, and the more the significant drop in HbA1c from baseline. There's also a consistent significant drop in fasting plasma glucose levels. Now, because these drugs have an action completely independent of insulin, they do not have any effect on the beta cells. Their risk of hypoglycemia is almost close to nil. So this shows that dapagliflozin in comparison to glipizide, that is of course the sulfonylurea, when we compare it, this study shows that 50% of subjects had hypoglycemia as compared to a mere 5% of subjects with dapagliflozin in combination with metformin, and it's understandable because of its insulin independent action. Now what about the extra glycemic benefits? Like we looked at earlier, because there is glucose loss in the urine, there is calorie loss, and as a result patients tend to lose weight. So over a period